Greetings and welcome to part 2 of the reproductive system for our Biology 112 class. Here we are talking about the reproductive system, the union of sperm and egg to provide the new offspring for the survival of the species human being. Last section we discussed male gender, anatomy, and physiology. And in this section, we're going to discuss female anatomy and physiology. Again, all these structures are going to revolve around the idea of helping the union of sperm and egg and also the growth of an implanted zygote. This first slide serves as an overview of the female anatomy and physiology. Let's start out with some structures we know already. Perhaps in this dorsal region, we might notice the sacrum, and we might also see the presence of the large intestine, and also notice the presence of some adipose tissue. Perhaps we're also aware from our last section, the urinary system, the presence of the urinary bladder, and we see the urethral orifice exiting. And now we get into some new structures. Let's look into these structures called ovaries in the back. We're going to watch out for these structures called uterine tubes. And then we see a structure called the uterus leading to the vagina and external genitalia. We're going to discuss the vulva later on. And then lastly, we discuss mammary glands and how they produce milk. So now we turn our attention to a view on the frontal plane. We have some gross anatomy of the ovaries. So we notice the location of these ovaries. These are going to be paired organs about the size of quote-unquote unshelled almonds. And we're going to find these in the upper pelvic region. And as stated earlier, we see that these ovaries then lead to fimbriae. They're going to lead to then go to the uterine, also called fallopian tubes, leading down to the uterus. Each ovary is supplied by both an ovarian artery and an ovarian vein. And we're going to have nerves supplied to the ovary via some sympathetic axons. It's noteworthy that the ovaries and testes are developmentally homologous. So similarly, we'll talk about other structures between male and female anatomy being homologous. Our first one are ovaries and testes. They both have reproductive functions and also endocrine functions. Let's talk about now some ligaments that hold these into place. We see that there is a broad ligament that suspends the uterus from the side wall of the pelvis. Then we have a double fold of the peritoneum, and we're going to call this the mesovarium, and that's going to attach to each ovary at the ovary's hilum. And this is going to be on the anterior surface of the ovary. That's where its blood vessels and nerves enter and leave. We also have an ovarian ligament present. This ovarian ligament is going to anchor the ovary to the uterus. In addition, we have suspensory ligaments. That's going to attach to the lateral edge of each ovary, and that's going to cover blood vessels to the ovaries. And lastly, we see a round ligament that attaches ovaries to the inguinal canal. So we see that the ovary on looker's right has a sort of cross-section cut away. And so we're going to look more in depth now into that cross-section of the ovary. In other words, how does this ovary develop its oocytes, its eggs? Let's talk about how this general structure of this ovary has an outer lining. We see that the outside of this ovary is surrounded by a fibrous tunica albuginea, and that's going to be covered by germinal epithelium. The germinal epithelium is getting its name where former anatomists believed that the eggs originally originated from. We will see otherwise here shortly. After that outer covering, we get to the cortex layer, and this cortex contains ovarian follicles. And then inside of that, we get the medulla, and the medulla region is going to contain branches of the ovarian blood vessels. We're also going to have some lymph vessels and some nerves running through there. Coming back into this cortex layer, we see follicles existing. We also see granulosa cells with oocytes in various stages of development. On the far right, we're going to see a mature, also called Graafian, also called vesicular follicle, and this is going to expel a secondary oocyte by the process of ovulation. Later on in our discussion, we discussed the smaller steps that lead up to that mature follicle and the steps leading up to that ovulation. So then coming back to some structures in the cortex, we see the presence of the corpus luteum. The name corpus refers to body, luteum refers to yellow, so perhaps we see a yellow body inside here. And this corpus luteum is going to contain the remnants of an ovulated follicle, but it has a dual purpose, and that is this tissue produces progesterone, estrogens, relaxin, and inhibin hormones, and then it finally degenerates. When it degenerates, we have the corpus albicans. And then we look into this medulla region. Again, as we said before, blood vessels, lymphatics, and nerves. So in summary, the ovary is an organ that produces both eggs for reproduction and then also hormones that also affect that reproduction as well. So we'll look at some of those hormones in a few minutes. Let's go back and look at some gross anatomy of the human body. We're going to look at the uterus, and we see its presence there. And we're going to take a more in-depth view now at the uterine tubes, the aka fallopian tubes. So let's see, we left off here at the ovary, and as we talked about earlier, through ovulation, this ovary is going to produce an oocyte, an egg, and then that's going to be whisked away by these fimbriae, these finger-like projections that sort of through cilia and other contractile motions pull the egg into these uterine tubes. Let's keep in mind that these fallopian tubes act to transport the ovulated secondary oocyte into the uterus, and then the uterus is going to be where the implanted zygote grows. The fallopian tubes is going to be the site of initial fertilization if it occurs. Let's go through some of the structures. We see this uterine tube or fallopian tube is narrow, but it's about 4 inches long, and it's going to extend from the ovary to the uterus. We see an open infundibulum here. This is going to be the funnel-shaped portion near the ovary. And there's again those fimbriae that are going to whisk that oocyte in there. The isthmus is going to be the narrowest portion where it joins the uterus, and in between the central region we have the ampulla. There's going to be some smooth muscle around the tube to help with contractile movements, and then it's going to have some endothelium that's going to be ciliated and also non-ciliated ones that produce mucus. So perhaps you remember that cilia are tiny hair-like structures on the end of cells. They have motile motions that help with movement, and then the non-ciliated ones are going to produce the mucus that the site needs. This is the common site of fertilization, and these are going to occur, this fertilization should occur about 24 hours after the ovulation of that egg, and then it's going to move into the uterus in about 7 days. It is noteworthy, recall that this fallopian tube is paired on the other side, in case we were not aware of that. So after the fallopian tube, we move into the uterus. The uterus is a sort of pear-shaped organ. It has thick walls of smooth muscle, and we can see that in addition to the other organs, it's located in the pelvic cavity. Notice the presence of a lumen inside, and this lumen is going to connect with those uterine tubes we talked about previously, and then inferiorly we will see how it articulates with the vagina. The uterus is generally angled forward. We might see that in an image here in a minute or two, towards the urinary bladder. And we also see that the uterus has several regions. So let's go over those regions. We see that it has a fundus in the superior direction, a main body, and then we get to the isthmus, and most inferiorly we wind up at the cervix. The cervical canal leads from the vagina to the uterus, and it has an inferior opening called the external os and a superior opening called the internal os. So therefore, the cervical canal is going to be between those two openings. Other noteworthy structures include the urogenital diaphragm, to which we have connective tissues that support the uterus. Recall that we have round ligaments, and then also we're going to have transverse cervical ligaments and uterosacral ligaments. Functionally speaking, we see a function for the uterus is to transport the spermatozoa, and also the function of menstruation. We talk about that more in a minute. And as mentioned earlier, at this uterus, we get the implantation of the fertilized ovum. That means this tissue is highly vascularized, ready to bring in oxygen and nutrients to the developing offspring. And of course, this is the region of the development of the fetus during pregnancy. And finally, when it's time to give birth to the offspring, labor contractions happen in this uterus. Here's a sagittal view showing some of that histology. We see that forward-leaning uterus is noted here. And by the way, that would be analogous to a couple slides back. You can compare slide 21 with this image to get an idea of analogous structures. Now we take a closer look at the uterus. We're going to look at the lining of the uterus, the tissues that compose the walls of the uterus. I'm going to start superficially and then move deep. So in other words, I'm starting at the bottom of the slide and moving upwards towards the lumen of the uterus. So we start with the perimetrium. The perimetrium is going to be the outermost covering, and it's going to be continuous with that broad ligament we discussed earlier. And then we're going to move into the myometrium. The myometrium is the middle layer. The prefix myo gives us a hint that we have smooth muscle. And then we move into the endometrium. That's shown well in this histology image. The endometrium is going to be the inner layer, and it has some intricate mucosa consisting of simple columnar epithelium, and then it's going to have underlying lamina propria. Let's look closer now at two layers of this endometrium. We see that we have the stratum functionalis, that is more deep, and then a little bit more superficial is the stratum basalis. Let's look at some subtle differences between those two. The stratum basalis replaces the stratum functionalis each month, and that would correspond with the female menstrual cycle. And the upper, more deep portion, the stratum functionalis, is shed during menstruation. This process is going to be regulated by hormones. So in summary, this is the tissue that's going to nourish the developing fertilized egg, if the egg gets fertilized. Now we look at the cervix. So we're coming out of that uterus, and we're seeing the cervix getting its name for a quote-unquote sort of neck region to this reproductive system. These in the cervix, we're going to have cervical glands that secrete mucus, and it's also going to block bacteria and sperm. When this is thin, the cervix is thin, it's going to be more receptive to sperm. So we can do a visual inspection to suggest the status of that. Both the cervix and mucus serve as a sperm reservoir. This mucus is going to protect sperm from the hostile environment of the vagina. The vagina tends to be rather acidic, and there's also phagocytes patrolling around that region. So the cervix with its mucus is going to protect that sperm. After the cervix, we arrive at the vagina, which is going to be a roughly 4-inch long fibromuscular organ. This thick-walled organ connects with the uterus at the cervix and acts as a sort of birth canal and the site of sexual intercourse. This vaginal wall is going to have 3 tunics, 3 layers. It's going to have an inner mucosa, middle muscularis, and an outer adventitia. It's noteworthy that there's a structure called the hymen. So this vaginal orifice is sometimes and often partially covered by a thin fold of vascularized mucous membrane called the hymen. If this orifice is completely covered, this imperforate hymen must be surgically opened to permit menstrual flow. However, it's more common that there's a partial covering of this structure. History might show us that sometimes this is a structure that gets inspected, again, visually for certain features. Notice that it's noteworthy that the hymen can be easily ruptured through vigorous exercise and activity, and is not always a good view that sexual intercourse has happened or not. So as we mentioned earlier, this vagina does function as a passageway for the spermatozoa and the menstrual flow, and it is also the receptacle for the penis during sexual intercourse, and lastly also the lower portion of the birth canal. So now we move into some external genitalia. We call the external reproductive organs, we're going to call these the vulva or pupendum. Let's look at some of the smaller structures within this vulva. First, we arrive at the mons pubis. This is a sort of fatty pad that's going to be over a bone called the pubic symphysis. This is covered by hair, and we then arrive at the labia majora. The labia majora are paired, thickened folds of skin and connective tissue. The labia majora, it's noteworthy, are going to be homologous to the scrotum in male reproductive external anatomy. The labia majora then bring us to the labia minora, and these again are going to be paired folds, but these are going to be immediately internal to the labia majora. The labia minora have no hair and are highly vascularized and contain sebaceous glands and numerous melanocytes. These melanocytes might give a certain pigment to this region. We also arrive at the vestibule. The vestibule is the space between the labia minora and contains the urethral opening and the vaginal orifice. On either side of the vestibule, we can see an erectile body called the bulb of the vestibule, and that's going to engorge with blood and increase in sensitivity during sexual intercourse. In addition, we have a pair of greater vestibular glands, and these are also going to be called bulbourethral glands. And these are going to be housed within the posterolateral walls of the vestibule, and they're going to secrete mucin. And mucin, in other words, is going to then form mucus, and that's going to act as a lubricant for the vagina, and that lubricant aids with sexual intercourse. Lastly, we arrive at the clitoris. The clitoris is a small erectile body usually a little bit less than 2 centimeters in length, and that's going to be located in the anterior region of the labia minora. So again, we talk about homologous structures between male and female anatomy. We see that the clitoris is homologous to the male penis, and that's because it contains two small erectile bodies called the corpora cavernosa and the corpus spongiosum. It's also noteworthy that this cavernosa becomes engorged with blood, and it becomes erectile during sexual intercourse. It's also noteworthy that this clitoris has many specialized sensory receptors that provide pleasure to a female during intercourse. And now let's switch gears a little bit and talk about mammary glands. So in summary, for everything up to this point, we've been talking about structures that accommodate and house the sperm for reproduction. And now we talk about how that offspring gets nourished after delivery. After pregnancy occurs and the delivery of the offspring, we need to give that offspring nutrients and certain essential micronutrients it needs to survive. And so Homo sapien, the species, has evolved with other animals in the animal kingdom to produce mammary glands. So I guess what I'm getting at is that mammary glands are modified sweat glands that produce milk. And the amount of adipose, and by the way, we can see that adipose shown in yellow, determines the general size of the breast. And we might recall from our 111 course, the previous course, that we have lactiferous ducts at the nipple. And we might also recall the structure called the areola, this darkened pigmented area around the nipple. Recall that these lobules are what's going to produce the milk. And these lobules then bring their breast milk to the lactiferous ducts. The lactiferous ducts lead to a lactiferous sinus, and then suckling by the infant is going to coax these lactiferous ducts into releasing the contents of the milk that is stored there. It's noteworthy that we have suspensory ligaments that suspend the breast from deep fascia, and that's coming up from the pectoral muscles. In other words, aging of these ligaments can lead to inferior movement of this organ. Lastly, it's noteworthy that the endocrine system produces a hormone called prolactin, and that hormone is going to cause milk production as oxytocin causes milk ejection. Turning away from external mammary glands, we look now at oogenesis and follicular development. So in other words, we're talking about the ovaries again. So here we go back into the ovaries. Oogenesis occurs in these ovaries. It results in the formation of a single haploid secondary oocyte. Recall that this is a process of meiosis, and again, students will want to generally familiarize themselves with the process of meiosis 1, which is a reduction division, and meiosis 2, which is an equatorial division. Lastly, in oogenesis, we're going to have maturation. Recall that, again, we're only going to get one viable cell out of this meiosis. The other three that result become what's called polar bodies. On the next slide, we'll take a look at some of the stages of follicular growth. So while oogenesis is occurring, the follicle cells that surround the oocyte are undergoing developmental changes. So in the next slide, we look at some of those changes step by step. It's noteworthy that a female is born with most of these primary follicles and primordial follicles before she's even born. In other words, millions are made in utero, but only about 250,000 survive by puberty. And then through ages 11 through 51, only about 500 are ever quote-unquote selected for ovulation. Then when the eggs are depleted, then we have the onset of menopause. So this ovarian cycle, this development of oocytes, is regulated by hormonal, hormonal control. So let's look closer now with an image at these follicular stages. First off, notice that these stages go in a clockwise direction. That's just simply to make the diagram palatable to the learner. Keep in mind that these stages occur in different locations in the ovary at different times. So let's start clockwise, going at 1. We get the primordial follicle. And by the way, students who are following along with their textbook will find good information corresponding to this on page 1100 of the McKinley textbook. So let's back up a bit to our anatomy of the ovary. We're talking about the cortex region of the ovary, and there are thousands of ovarian follicles in this cortex region to the ovary. So an ovarian follicle consists of an oocyte that is surrounded by supporting follicle cells, also called granulosa cells. In this, we're going to see 6 main types of follicle. We're going to run through their stages of development. Let's go through each one of them. So first, we arrive at the primordial follicle. That's going to be our most primitive follicle, and it contains a primary oocyte that's going to be surrounded by a single layer of flattened cells. Referring ourselves to meiosis, the primary oocyte is an oocyte arrested in prophase 1 stage of meiosis. Then a primary follicle forms from a maturing primordial follicle. So that means we're on step 2 of this diagram. And that's going to contain a primary oocyte surrounded by 1 or more layers of cuboidal granulosa cells. And then we also have some connective cells that surround that as well. These connective tissue cells are going to secrete androgens, which are converted to estrogen by the granulosa cells. Thus, the primary follicle secretes estrogen. Pardon me. Moving from the primary follicle, we get to the secondary follicle, stage 3, shown in the diagram. This secondary follicle develops from the primary follicle and contains a primary oocyte surrounded by, again, many layers of granulosa cells. Here we begin the development of a structure called the antrum, and this is going to be a sort of serous, fluid-filled structure that develops in the secondary follicle. Perhaps a noteworthy thing is that antrum means cave, so to speak, in other previous languages. So as this oocyte is in the late secondary follicle stage, shown in 4, the primary oocyte has now developed 2 protective surrounding structures, the zona pellucida and the corona radiata. This outermost protective covering, the corona radiata, is going to be a layer of cumulus oomorphous cells. And then this zona pellucida is going to be a translucent structure that contains glycoproteins. The purpose of that zona pellucida is going to be to block polyspermy, to block multiple entrants of sperm. And then we arrive at the mature, also called Graafian follicle. And we can note that by the nice large presence of the antrum. And then leading from our Graafian, aka mature follicle, we arrive at ovulation. The oocyte is released. Left over from that ovulation is tissue called corpus luteum. And as we talked about earlier, it has a function of secreting hormones. And then what's left over after that corpus luteum, in other words, yellow body, is a white body, corpus albicans. It's generally just sort of scar tissue that's left behind. It's noteworthy that meiosis II only occurs when the sperm penetrate the oocyte, and therefore it becomes the ovum. So in summary, those are the stages of follicular development leading up to ovulation. Here is a good diagram to push pause on. It compares meiotic events with the follicle development in the ovary. Feel free to push pause and study this image well. So let's now take a look and shift our our viewpoint into the hormonal influences that affect the ovarian cycle and then also the menstrual cycle. So let's back up a bit and review that prior to birth, this ovary contains millions of primordial germ cells. And then at birth, both of these ovaries contain together approximately 1.5 million primordial follicles. And then after birth and during female childhood, these ovaries are generally inactive, and many of these primordial follicles are going to be just simply destroyed. That means by the time a female reaches puberty, there are generally about 400,000 primordial follicles remaining. And that leads us to this slide, that when a female reaches puberty, the hypothalamus releases gonadotropin-releasing hormone, abbreviated by GnRH, in a sort of pulsating manner. Now we might recall that we have some structures in the brain left over from the nervous system. Here on the upper right, we see the hypothalamus connected to the pituitary gland, and these are going to release certain hormones. Recall also that the ovary as well is going to release hormones. So notice how these two structures influence each other back and forth. So this GnRH is going to stimulate the anterior pituitary gland to secrete follicle-stimulating hormone. That's abbreviated as FSH. And then it's also going to release LH, luteinizing hormone. And FSH and LH are both responsible for initiating the ovarian cycle. So this ovarian cycle is generally about 28 days long, but it can range from 21 to 35 days. This ovarian cycle correlates with the menstrual cycle, and this menstrual cycle has a follicular phase and a luteal phase that is separated by ovulation. Let's look at a few of these hormonal cycles that occur. By the way, before we move on to the slide showing the hormonal changes, it's noteworthy that the menstrual cycle involves changes in the endometrium. As discussed earlier, we're going to have tissues that slough off and move away. But of course, before that menstruation occurs, the uterus is theoretically preparing the uterus to receive the fertilized ovum. If that fertilization does not occur, and if implantation does not occur, then the stratum functionalis is shed during menstruation. Let's look at a few of these phases now that are affected by hormones. And by the way, here's another nice slide to push pause on and observe the relationship between pituitary gland and ovary with the hormones they release. So let's talk now about these hormone levels in the ovaries. Let's start off by familiarizing ourselves with the graph. Notice on the x-axis we have 28 days, or I should say days, ranging from 0 to 28. Noticing that this is a cycle that repeats every 28 days. And on the y-axis we have hormone concentration. Each colored line relates to a certain presence of hormone. So this first phase, 0 through 13, is going to be called the follicular phase. This is where FSH and LH stimulate up to about 20 primordial follicles to mature into primary follicles. And then we're going to get into the ovulation that's going to occur. And ovulation occurs on usually about the 14th day of that 28-day cycle. And then we arrive at the luteal phase. That's going to be days 15 through 28 of that ovarian cycle. Observe how we have changing levels of estrogens and especially luteinizing hormone that lead up to that ovulation phase at day 14. Notice also the levels of progesterone, which peak out after that ovulation. Recall that birth control is a synthetic way that we might mimic these hormonal changes of progesterone. And here we have phases of the female menstrual cycle. Notice that this diagram relates the uterine walls on the bottom of the diagram, showing the ovarian cycles in the middle, correlated with the actions of the pituitary gland. So as we mentioned earlier, we have 3 phases of this menstrual cycle. We have the menstrual phase, the proliferative phase, and the secretory phase. And these are all going to be correlated with changes in hormones. So let's look at some of these relationships. The first 13 days of this 28-day ovarian cycle is going to be the follicular phase. And as we mentioned before, FSH and LH are going to stimulate many primordial follicles to mature into primary follicles. Then inhibin, you might recall, is a hormone that gets released. That's going to be secreted by the follicles, and that's going to inhibit FSH and LH secretion, thus causing no more follicles develop, and then also causes existing follicles that already exist to develop further. Then we see, as time moves on, a few primary follicles become secondary follicles, and again the others are simply destroyed. Late in this follicular phase, generally only one secondary follicle develops further, and again the others are destroyed. Under the influence of this luteinizing hormone, LH, that secondary follicle develops increasing amounts of fluid in its antrum, and that's going to push the primary oocyte to the edge of the follicle, as we can see in the diagram. This primary oocyte in the secondary follicle is going to undergo a further meiotic division. It's going to complete meiosis 1, and then it's going to stay in that phase of metaphase 2. And then we see that there's, from the other graph, there's on day 14 of this cycle, there's going to be a peak in the luteinizing hormone secretion, shown in the pituitary gland up top. With this LH surge, we're going to get an increase in the formation of that antrum fluid. This increased pressure of the fluid forces the secondary oocyte out of the follicle, and the expulsion of this oocyte out of the follicle is what we're going to be calling ovulation, shown here in the diagram. Then we have remnant tissue left behind. That's going to develop into that corpus luteum, and now we get what's called the luteal phase beginning. The corpus luteum is going to secrete progesterone and estrogen, and that's going to stabilize and build up the uterine lining. And hopefully this stabilization and buildup is going to prepare for a possible implantation of that fertilized oocyte. This corpus luteum has a lifespan of about 10 to 13 days within that 28-day cycle. And if the secondary oocyte is not fertilized, and if this fertilization does not happen, then the corpus luteum becomes the corpus albicans, which is that white connective tissue we see on the far right. So if the oocyte does not get fertilized, then the corpus luteum will regress. Thus, it's not producing estrogen, it's not producing progesterone any longer. So therefore, with no further estrogen and progesterone stimulation of the uterine lining, it sloughs off and then it sheds away in a process called menstruation. So in summary, we see how the ovarian cycle and menstrual cycle are both affected by actions of the pituitary gland. Let's turn our attention now to pregnancy changes. As we talked about earlier, both estrogen and progesterone are secreted in large quantities by the corpus luteum. Again, if fertilization does not occur, the albicans is formed. We get hormone levels dropping. Then the rise of GnRH, FSH, and LH are going to restart that cycle. It's noteworthy on the bottom part that ectopic pregnancies can sometimes result. This would be where they fertilize oocyte plants in the uterine tubes. That's an unfortunate situation because that fertilized zygote should be implanting in the uterus. And so the extraction of that fertilized oocyte in the uterine tubes is an unfortunate surgical procedure. This slide we're only going to touch on briefly. This is a couple menstrual abnormalities. This is not discussed in the textbook, so I think we'll kind of move on to some other material. And this slide talks about birth control method. It's interesting that abstinence is the only 100% reliable form. Any other type of birth control method does not have a 100% birth control history. In other words, condoms are less than 100%, and also timing is less than 100% as well. So some other birth control methods include tubal ligation, and also males get a sort of cut in their tubes as well, a vasectomy, ectomy referring to cutting of, vas referring to the vas deferens. We're going to wind up this discussion today with some homeostatic imbalances on the female reproductive system. And we see that aging has an effect on the female body. As we mentioned earlier, we mentioned that after the last egg exits, we get the onset of menopause, the last menses. And so this is going to happen around between the ages of 40 and 50. These ovaries are going to become less responsive to the stimulation of gonadotropic hormones from the anterior pituitary, in other words, GnHR. As a result, estrogen and progesterone production decline, and those follicles in the ovaries do not undergo that normal development that we just discussed. Some symptoms of menopause include hot flashes, copious sweating, headache, vaginal dryness, depression, weight gain, and emotional fluctuations. Also, there's some possible links with cancers as well. Another homeostatic imbalance in the human body is endometriosis. Students who are following along in the McKinley text will find more in-depth information on page 1110. And endometriosis occurs when part of the endometrium is displaced onto the external surface of the organs within the abdominal cavity. So in other words, tissue becomes discharged from the open end of the uterine tubes during menstruation. This could be a result of retrograde menstruation, and that's going to allow some of that menstruation to escape into the abdominopelvic cavities. This is going to cause pain and scarring and possible infertility. There can be a hormonal influence that causes this endometriosis. Another homeostatic imbalance in the female reproductive system is breast cancer. McKinley discusses this in depth on page 1115. And breast cancer is the second leading cause of death for women in the United States. In other words, Breast cancer affects approximately 1 in every 8 women in the United States of America. It is quite not common in males. Some risk factors for breast cancer include a longer reproductive span, obesity, and a later age at first pregnancy. There's also influence of estrogen. Some studies suggest that increased exposure to estrogen over a long period of time can result in breast cancer. Shown on the lower left is that tumor, that malignancy that shows the breast, and it's malignant cancer tumor. What can we do about breast cancer? Early detection is a good choice. Females should perform self-breast exams and have medical breast exams on a routine basis. Another type of homeostatic imbalance in the human body is ovarian cancer. Students can read about this on page 1104. And this is going to be the 6th most common form of cancer in a female. The textbook says 5th most common female cancer. And this is going to arise from the oocytes, the connective tissue, or the surface epithelium. This ovarian cancer is difficult to detect because there's no exact signs or no exact symptoms. So therefore, treatment is usually a combination of surgery and chemotherapy. Here's a rough picture showing possible ovarian cancer. Another homeostatic imbalance in the female reproductive system is cervical cancer. Students might jump to page 1110 to get in-depth read on this. And similarly, we see cervical cancer is another very common malignancy in the female reproductive system. It's going to start with cervical dysplasia, in other words, changes in shape and growth and number of cells in the cervix. And we could diagnose this early with a pap smear. For causes of this, current research is showing that the human papillomavirus, HPV, is a very frequent suspect when it comes to finding the source of this cancer. One way to protect against this is to get the vaccine. A Gardasil vaccine will provide protection for girls and boys. And that does conclude our summary and highlights of Chapter 28. In other words, the male and female reproductive system. And with this being our final lecture of the series, I'd like to thank you for sticking with me and all of your attention. I'm looking forward to seeing you guys at the exam, and best wishes in your studying endeavors. Have a good day.